What's up, Z-Pack? Come on in. We're doing a different thing today. We actually scheduled the live conversation, the Ask Z Anything, and we got kids over there screaming. Victoria, my lovely assistant, is going to be reading your comments today. Say what up, Victoria.
What's up,
What's
everybody?
Victoria is a muggle and non-medical person, so she is a perfect counterpoint to my medicalness. Come on in. We're taking any kind of question live. Cynthia Ijogu, who is a supporter on Facebook, is here. Dizzy Ms. Lizzie is here, and that's a good handle. And who else we got? Karen Voigt is here. Thoughts on respiratory therapist Jose Gomez? Well, it doesn't matter what my thoughts are. The truth is they're awesome. We can't run without them. They're underappreciated. We did a music video called Ventilate, which was Nate Dogg and Warren G. Got to ventilate. So y'all know I love you. What up, Ruth? What up, Brandolyn? You missed my birthday. Well, I'm sorry, Brandolyn. Cynthia sent us a little money. Thank you. Have you made a decision on the CME yet? Karen Voigt. So Karen is a supporter on Facebook. Also on Patreon, we've been offering CME. Now, what I found out, these continuing medical education credits, what I found out is that I've been putting a lot of energy and it costs money to get them accredited and all of this. And like the last one we did, only 26 people actually went through the process through Physicians Weekly and actually claimed the CME credit. And I'm like, why am I busting my ass to do this if you guys don't want it? So maybe I'll stop spending money, time, and effort on that and focus more on the content.
I think we have some questions, Z. Mac Death wants to know what happens to your head during a concussion.
Ooh. So it's interesting. Many things can happen to your head during a concussion, but one of them, if you really, really, really overdo it, is something called axonal shear, where the neurons actually shear relative to each other because as your head stops moving when it hits something, your brain doesn't necessarily stop moving. It goes, and that momentum can cause damage to neuronal tissue. It can cause damage to blood vessels. It can cause swelling. It can cause a lot of problems that ultimately result in symptoms, including things like memory loss, delayed bleeding, and long-term problems like what we used to call dementia pugilistica, which is the dementia that results from being pummeled constantly in the head. So boxers get this. There are a lot of people doing studies on this now, including Cleveland Clinic, Las Vegas, and other people like that. So, by the way, Variables of Light, which is Logan, asked a question. He's on our team, and he said, AIDS, real or nah? I don't know, Logan. With you, the AIDS is totally real. And it's not just HIV, it's full-blown AIDS.
Alex Porula asks, any advice for us medical students trying to get into a competitive residency program?
Any advice for medical students trying to get into a competitive residency? So now last week we got asked about medical students, how do they get into med school? Now we're asking, how do we get into a competitive residency? So the bottom line is a lot of it depends on your evaluations from your clinical rotations. If you're a school that has grades, they kind of look at that, and then board scores. So board scores, it depends. Like a lot of internal medicine programs didn't look at board scores because they didn't consider it that important, but ortho, radiology, dermatology, they weigh them quite highly. So you got to kick ass on all those things and actually be passionate about the field you're looking into doing. So that actually helps a lot. So if you've done some research and stuff, I didn't do any research in residency. It didn't matter. Still, or in medical school, and it didn't matter because I still got the residency I wanted because my evaluation said that he kind of kicks ass. He cares about medicine. He cares about his patients. He communicates well. He presents his patients concisely, and he's an outstanding student. That helped a lot. So you just got to kick ass. I don't know if that's very helpful, but residency is a different animal. And also make sure that your ranking place is really where you want to go, and that rank order thing is very important. But you already know this. What do we got?
Variable Light wants to know shingles or just a fancy chicken pox.
Variables of Light is Logan. And he's saying, what did he say? Shingles
or
just
fancy
chicken pox or nah? Well, Logan, with you, again, it's just herpes. And I think trying to deny that it's just straight genital herpes is going to get you in a lot of hot water. Just go on the Val acyclovir and suck it up. I know it's expensive, but you got to do it.
So Jonathan Sellers wants to know, as a high school student, can I shadow a doctor? How should I come to one to request shadowing?
As a high school student, should I shadow a doctor? Well, if you're interested in medicine and you don't know enough about it, you kind of have to shadow. You either have to shadow, go do some volunteer work, go abroad, go domestically, it doesn't matter. But you got to see what's going on. For me, I'd been shadowing doctors all my life because of my parents, and I would get dragged to work, I'd sit in the physician's lounge, talk to other doctors. It was exposed to me since I was in vitro because my mother was a pathology resident while pregnant with me, and then ultimately changed to psychiatry because path was gross. But I remember totally being in the womb and being exposed to all. I don't remember any of that shit, but you have to be exposed to it. So if you have no medical people in the family, you do need to find somebody to shadow. I think we have to be careful about shaking this camera for some reason. Look at that.
Oh, that was me.
It's me too. I think we have to I thought the thing would stabilize it, but it's ghetto. Ryan Tate says, born a doctor. Sadly, it might have been the case in my case. How do you feel about RNs going on strike, Betty McLean? I have very mixed feelings because I think a union is a great way to stand up together. And I talk about standing up together because when you stand up alone, you get beaten down. But at the same time, there's a lot of abuses with unionization, a lot of bureaucracy, and honestly, if I could wave a magic wand and make it unnecessary, that would be great because we'd all be on the same team, skin in the same game, collaborating with each other. There wouldn't be this antagonistic. Kaiser almost had everybody go on strike this last week, almost everybody nationally. And it would have cost them, how many hundreds of millions, billions of dollars. But the bottom line is, why has it gotten to that point? It shouldn't be this antagonistic thing, but it is. So we have to fix that. So how do I feel about it? I feel heartbroken that nurses have to go on strike. But at the same time, I support their right to collectively organize and bargain, especially when they're being abused, which in many cases they are. But at the same time, the problem with that is we get this antagonistic thing where it's us and them. And we really need to try to get beyond that because it should be a collaboration in healthcare.
So Michael McHugh wants to know if you're concerned about misinformation among healthcare professionals impacting patient care.
Misinformation among healthcare professionals. So if you're talking about silly anti-vaccine belief among doctors and nurses and things like that, yes, I am, because that's just crazy. It's rare though, but it does happen. Other misinformation you have to be very specific in this question because are you talking about the misinformation that comes from pharmaceutical reps teaching us about their drugs or the bias that comes from getting gifts from pharma, or are you talking about the misinformation that comes from half of what we learn in medical school is probably not true, but we don't know which half? So there's a lot to that question to unpack, which without knowing more, I couldn't unpack for you. What do we got?
So Ruth Baran wants to know how serious sepsis is that starts in the heart and what is the treatment? How
serious is sepsis that starts in the heart and what is the treatment? So sepsis that comes from a heart infection like endocarditis or a valve abscess or bacterial pericarditis would be a strange one, but those sort of basically sepsis of any source in the heart is particularly concerning because you have to address the root cause of sepsis in every case. And addressing the root cause of sepsis in the heart is often not just antibiotics, but it can actually be surgical. And when you have sepsis, which is the systemic inflammatory response to infection that leads to things like very low blood pressure, organs that don't get enough blood flow, leaky capillaries that lead to fluid in all places that you don't want it, like in the body tissue and in the lungs, and multi-organ failure and dysfunction. If you're in that situation, it's kind of hard to do surgery because you're not stable. So it depends on the cause of the heart sepsis, but sepsis in general is a serious problem. You want to catch it early, treat it early and aggressively. And often protocols can help, but just having a very high index of suspicion is the key thing to managing sepsis effectively. What we got? Do I have any experience with Ehlers-Danlos syndrome, Jonathan Conrath? Well, yes, we had Cybabe, who is a big social media personality, talks about science. She has EDS. We've talked about it on the show with her. If you search Cybabe, ZDoggMD, you can see that interview. She pulls her joints back, does a lot of stuff. I forget which type she has, but it's a complex connective tissue disorder that's a little bit difficult sometimes to diagnose. It's often missed, and it causes quite a bit of suffering. There are a lot of Z-Pak followers who suffer from it. We actually raised money for an EDS charity on Facebook once. So it's a real thing, and the key thing is having the index of suspicion being high so that you can start to explain diagnosis to people who've maybe suffered without having a diagnosis, which is very difficult. And it can cause a lot of chronic pain too, as well as other issues. What we got?
So Lee Dinning wants to know how to convince our stubborn old folk to get their shots. They don't seem to think they're anti-vax when I confront them.
So stubborn old folks. So the kind of shots that, hey, what up, Z-Pup? kind of shots that old folks need to get are things like flu shot, which they don't realize is so important because flu preferentially kills the elderly and the very young and the immunocompromised. Pneumovax, which again, if you can reduce the rate of pneumonia, which is a killer of old people, why wouldn't you do it? And there's really no complications. And things like the shingles vaccine, which is more of a lifestyle quality of life issue. The new Shingrix vaccine is like 90% effective. It's really, we're all trying to get. What are you doing?
I want to show you something.
No. So this is actually a serious show. Yeah. So
Super serious because
what?
people are dying.
Yeah, people are dying. So Shingrix is another one that it's kind of hard to get because it's so popular now because people would rather, they really do want to be protected against something that's incredibly painful and debilitating like shingles, which is this kind of recrudescence of what's effectively the chickenpox virus later in life. It hangs out in the nerve root endings and causes drama. What we got? So
Kayla,
bottom line, old people, get your damn shots. Stop being a bitch.
okay, so Kayla wants to know, what do you know about the Antelope Valley Hospital in California dumping a seizing patient with a spit mask and placing them into a parking lot at night? I've looked into it and it appears to be true. Is it?
I don't know. Sounds like a crazy story. Hospitals have done weirder things, but usually not intentionally. We've done these stories about like the Baltimore psych patient that was quote unquote dumped into the street and all these other things. And when you dig into it, you realize there's always more to the story than what you hear. So I wouldn't necessarily believe that at face value. I would never believe the press without being able to talk to actual staff. And remember that staff in hospitals are hamstrung. They can't talk to you because of HIPAA, whereas the press can say anything they like. They can talk to any eyewitnesses. They can talk to the patient's extended uncle, Jerome, in 3 states down, who's like, they left him out on the street to die. But the staff can't say shit because of HIPAA. So there's that. So just keep that in mind. Again, I don't know the specific story.
So Ione Anderson wants to know how you feel about the use of mushrooms as antidepressants.
So you're referring to the psilocybin-containing mushrooms as antidepressants. This is how I feel about it. I think it should be studied more. I think it's very promising. It's one of the few new approaches that has shown such promise and yet is so stigmatized because of Timothy Leary in the 60s and other things. You should listen to Michael Pollan's book on audiobook, How to Change Your Mind on Audible. It's a great introduction to the idea that psilocybin can be used not only for severe depression, PTSD, et cetera, but for the betterment of well people. With a guide and under a degree of scientific rigor, which I think that's the thing. You don't just go and do a bunch of mushrooms, go out into the forest, because set and setting, your mindset going in and the setting that you do it in and the support that you have is key. Otherwise, you could make things worse. And there are cases of people unmasking psychosis and doing other things without the proper support. So don't just go out and do a bunch of mushrooms, but I think it absolutely could be one of the more transformative things that we do moving forward for depression, anxiety, and the betterment of well people.
Master of Puppets, can mold exposure cause kidney swelling and pain?
Can mold exposure cause kidney swelling and pain? So the first thing I need to address is that the name Master of Puppets, referring to Metallica, yes, I approve of this message. The second, Master of Puppets, I'm pulling your strings. The second thing is this mold and kidney disease. I don't know the answer to that. So I'm not experienced in mold causing kidney failure and things like that. So I don't know the answer to your question. Mold is often blamed for a lot of things. Unfortunately, unless it's like something like aspergillus in an immunocompromised patient, in which case you can get aspergillomas, these little growths of mold throughout the body, anywhere, lungs, kidneys, anywhere, brain. Just your standard garden variety mold, I'm not familiar enough with it causing those things. And I suspect we're over blaming it for those kind of things. It can cause allergic hypersensitivity and other issues like that, but I have not heard about those other things. This is a good one. Madeline Socks. What happens when a patient misses dialysis? So, Miss Victoria, do you know what dialysis is?
I do. My mom's friend went for treatment when I was younger, so we would take her and then go get her food and then bring her home at the end.
Is that right? So how long did the dialysis take?
I mean, I was little, so I felt like it took forever. But I don't know, at least an hour. It was probably maybe 3 hours, my whole day felt like.
It can often be that long. And it does feel like forever, especially the person on dialysis. And it's very much a pain in the ass. And I think that's why a lot of people are non-compliant with their dialysis. They don't show up. Also, sometimes it's not easily, especially if you're undocumented, it's not covered. And then you have to go to the ER for dialysis. So this has been a major problem. So there's plenty of obstructions to getting good care in terms of dialysis. Do you know what it does for you? Do you have a sense?
It cleans your blood or filters it out.
Exactly. So it's trying to, in fact, the technical term for dialysis is renal replacement therapy, RRT, because you're trying to replace what the kidneys do, which is several things. They remove excess water and fluid. They remove toxins like, urea and other things like that need to be removed, nitrogen-containing waste products from protein synthesis and protein digestion. And they balance our acid base in the blood and our electrolyte balance. And so these are very, very important. And they secrete hormones like erythropoietin, which help us make red blood cells. And they control our blood pressure to some degree through the renin-angiotensin system. There's a ton of stuff. The kidney is one of the smartest, most complex organs in the body. So how do you replace it when it's failing? Well, you start to look at the constituent parts and you fix them. So dialysis is one way, by artificially using a membrane to filter blood. So what happens if you're not compliant? Well, a lot of people are on full-on dialysis. I'm not talking about peritoneal dialysis, like full hemodialysis with the fistula, the blood, and all that, usually 3 times a week. And if you skip a dialysis, well, several things can happen. Your electrolytes can get out of balance, so your potassium can get so high, or your magnesium gets so high that you have a heart arrhythmia and die. Your fluid balance can be affected so that you get so much fluid in your body that you can't breathe. So it ends up going in the lungs or in the body tissues. Or you end up with something called uremia, where the toxin level is so high that you can't think clearly and you go into an altered state of consciousness, which is not necessarily pleasant. So those are just 3 things that can happen with skipping dialysis. So it's important not to skip, not to miss dialysis. And it's important to teach our patients about this.
Faraz wants to know any information you have about long-term stimulant use, ADHD TX, or similar, and risk for vascular renal disease.
So long-term stimulant use for ADHD treatment, and is there vascular? So here's the thing. I actually don't know the answer to this in terms of the long-term deleterious effects of things like Adderall, which is a stimulant for ADHD. I would have to research it specifically and look at the specific studies on that, but I would say this. If that drug helps you, then you have to always weigh risk and benefit. If you're able to function better on Adderall than not, and you're not jittery all the time, you're not hypertensive, there's not other problems with it, then obviously it's a balance, a risk-benefit balance that weighs in your favor of using the drug. If not, then you really have to decide, are there other ways to manage your ADHD that are non-pharmacologic? And some of those can be, some cognitive behavioral therapy, some training. Some of that can be meditation, believe it or not. It's hard, but it can work. And some of it can just be like, okay, I'm going to roll with it. And I'm just, the way my mind works is unique. And I am going to find a career where being a little bit squirrel is helpful. For example, being me. So that's my answer to that.
Okay, I have a really good question from Valbona. Tips on conversations about end of life, withdrawing care with patients and their families.
What a great question. This is very complicated, and my hospice and palliative care colleagues do this a lot better. How do you talk to people about end of life? Well, the first thing is to talk to people about this stuff. So most of us don't even start the conversation because we're scared of death ourselves. We don't get necessarily paid for it. It opens up a bag of whoop ass. We're worried the patient's family going to rip us a new one on Yelp or patient satisfaction surveys or Press Ganey. And so we're scared to talk about this stuff. The way I always did it as a hospitalist is the fact I just tell people, I'm like, okay, so here's the thing. We're getting to this point now where we need to talk about what are your wishes, because we're doing a lot of stuff to you, and I'm worried that we're doing stuff to you that isn't necessarily doing stuff for you anymore. Like, I can do stuff to you all day. I can put you on this, I can put you on that, but the question is, what do you want? What are your goals? Do you want to see your daughter graduate? Do you want to be comfortable at home? Do you want to live as long as you can? Do you want to, what do you want to do? And once we know your goals, and I could tell you, well, if you were my mom or my dad and they had those goals, knowing what I know as a clinician, I would tell you X, Y, or Z. And that way it becomes personal for me, but also professional. It becomes personal and tailored to that patient. And so sitting down, sitting in a chair, eye to eye, hand on hand, and having that conversation is so key with eye contact and true expression of curious compassion. Like, you care about this person, you want to help them achieve their goals, and that means having difficult conversations that are also hard for you, because these are hard conversations. I recommend reading the book by a wonderful doctor who was on our show, Sunita Puri, called That Good Night. And it's about her path to becoming a hospice and palliative care physician. She's at USC. She's the head of their department, I believe. And she writes in the book a lot of wonderful vignettes about what she's done right and wrong in having those conversations. And I think it was very illustrative to me on how I can better frame and understand my patients and how to talk to them about this stuff. It's so important. It's one of the most important things we do, and we do it poorly more than anything. Risa said she loved that book. Yeah, it's a great book. So, and again, just search on my website for Sunita, Sunita, and you'll find the post with the links with the interview. What we got?
Okay, so Mithun asks, thoughts on clinical mobility, specifically mobile devices in the clinical environment, potential to truly positively impact patient safety by enabling efficient caregiver communication in real time.
So mobile devices as a communication platforms to improve safety in the hospital. So it's interesting, they recently did a survey. The vast majority of patients feel that technology and mobile devices have made their health better. Now, whether that is actually borne out by data is hard to actually quantify. But I would say this: if you're able to use devices, for example, a Fitbit type device, or the Apple Watch recently made news by being able to potentially monitor for falls, because you get a sudden particular type of velocity of acceleration in a fall, in which case you could probably set it to alert somebody or to call 911 or do something like that. And I think in an out-of-hospital setting, that could be interesting with all the false positives that could happen. In the in-hospital setting, I think this kind of thing. So we did a show with a company called Banyan. You were there. We went out to Marin, and they use a virtual telenurse in the room, a big camera, to be able to monitor for falls. So they have a person in a room that's looking at multiple cameras, and they can see when a patient's trying to get out of bed and prevent the fall by alerting the nurse or getting on the microphone in the room. Hey, Mr. Edwards, what you doing, son? Like, this isn't Dancing with the Stars. You need to chillax. By the way, a little twist on that. Some recent, I think it was the Atlantic or something, they did an article. We've gotten so obsessive about preventing falls in the hospital because it's something you can measure. Mm-hmm. So hospitals can be dinged on it, right? Because if you can measure it, then someone can punish you for it. Mm-hmm. So since it's easily measurable, how many falls do you have? It's an easy number to try to optimize. Well, okay, we're going to have no falls. How do you have no falls, Victoria? What would you think would be a way to prevent patients from falling 100% of the time?
We got to lock them all down.
Lock them all down. So if you tie a patient down, or you tell them they can't get out of bed, or you discourage them from ambulating, meaning walking. We like to use big words because then people think we're smart. If you prevent them from ambulating, well, they're not going to fall, but they're also going to lose strength every single day. They're going to get bed sores. They're going to become more debilitated, more likely to get pneumonia or opportunistic infections. So we used to have a rule of thumb in the hospital. Every day you're in the bed is 2 days of recovery time for physical therapy. And I found that to be true. Maybe a little underestimation. I think maybe even more. So we need to help our patients get up, and that does put them at risk for fall. But I think it's a risk-benefit analysis again. So if we can keep them safe while they're getting up, and if mobile technology helps that, then all the more power to it. But something we need to be talking about. What is an opportunistic infection, says Luis? An opportunistic infection, so an opportunist is somebody who takes advantage of something. So an opportunistic infection is a bacteria or a virus or a fungus that takes advantage of a weakened host. So if you have a low immune system for whatever reason, so in HIV patients, when they develop the full acquired immune deficiency syndrome, they get opportunistic infections. So since their immune system's knocked down by this virus, these opportunists come in like yeast and Kaposi sarcoma due to this HSV6 virus, and these sort of things that would never attack a normal, fully immune person, but are opportunistically infecting people with weakened immune system. Hope that's the answer you were looking for. I hope that's right. I make this shit up as I go, guys. Come on.
Robin Taylor, was suicide among other students a problem in your medical class?
Was suicide among other students? Not in our class. So in our specific class, we did not, thankfully, have any suicides. We had a lot of depression. We had a lot of anxiety. We had one person who had a frank psychotic break. Like, it was clear. And we had somebody who clearly had anorexia. We had somebody, I mean, it was a petri dish of behavioral health issues. And I put myself in it too, anxiety, depression, all that. But we didn't have suicide. However, other classes did. And however, at Stanford, we had a wonderful surgical resident die by suicide. And this person had everything going for them from outward appearances. So this is something that's been stigmatized. It's something that I think is a huge problem. We've talked about it before, and we need to do a lot better at being able to provide support to each other, because it's really hard what we do, really hard. I absolutely would have thoughts when I was a medical student that it would be much better to be dead than have to go in and round tomorrow and be humiliated on rounds. Like, it felt like that, right? So imagine if you're already depressed, it's going to make it a lot worse. So we have to be open-hearted to that, and also have a pragmatic approach, which we don't yet.
Brenda McCoy wants to know what to do about my husband needing more chemo, but already owing the doctor, hospital, more from the last treatment.
Ooh. So chemo is the only country, I think, where you can literally, only developed country where you literally go bankrupt if you get cancer, because you can't pay your bills. It's totally screwy. So I'll just give you this story. So Tom's dad, Tom Heineber, the producer on our show, he's told this story in an interview with me. His dad had prostate cancer, recently passed from it, advanced prostate cancer. And his oncologist, in my mind and in Tom's mind, really never had the conversation about what are your goals, what are your wishes. And part of it was, I think his dad was in deep denial about it. And so what ended up happening was it was just chemo and chemoembolization and all these things that I knew as a doctor weren't going to help, but they were peddling hope to him. And he would get bills for like $100,000 for these experimental treatments that, it was insane. Tom did a show about this, and it was just heartbreaking to watch, because we could all put ourselves in this position. So what's my advice? My advice is, first of all, make sure you get a second opinion. Make sure that chemotherapy is even appropriate, necessary, and helpful? Or are you just going down a path that is laid out by a person who is a hammer and sees the world as nails, right? So just be really, really careful about that. And I wish him the best of luck, and I wish you the best of luck. It's a very, very hard process.
Rachel Gal wants to know, are physicians educated about postpartum preeclampsia in med school? I'm recovering from it and the issues that came about because doctors did not recognize it right away.
This is a really interesting question. Postpartum preeclampsia. So, Victoria, do you know what preeclampsia is? And if you do, I'll be surprised, because you're
Does it happen?
not a medical person.
Does it happen with pregnancy?
Yes.
I think it happened. Okay, that's as much as I know.
Good. I'll just throw out a question to you. What do you think the cure for preeclampsia is if it's associated with pregnancy?
You're asking me tough things.
I am.
I'm sweating. Not being pregnant?
She's kind of smart, guys. She's kind of smart, right? That's why I hired her. I don't hire dummies, except for Tom and Logan. So it used to be taught that the cure, and it still is taught, the cure for preeclampsia is delivery of the fetus. So by inducing birth or letting natural birth happen or whatever it is, you cure the preeclampsia. Now, preeclampsia is a condition where you get this horrible cascade of events with hypertension, protein in the urine. You can actually have a stroke and die, and it happens. And we miss it in the hospital. And there have been articles recently about mothers who've died of this, missed in the hospital, because we don't have good processes and good systematic improvements in the hospital to keep our mothers safe. And it's disgraceful. It's absolutely disgraceful. The rest of the developed world does better than us at this. We have horrible maternal mortality, horrible infant mortality. It's inexcusable. We're the greatest country on earth, goddammit. Why can't we do better than this? So this being said, there is a phenomenon, I believe, and again, I'm not an expert in this, of postpartum preeclampsia. In other words, the delivery doesn't cure the preeclampsia, or you even develop it post-delivery. And whatever you call that syndrome, it needs to be managed aggressively, and so you need to have awareness that it can happen. And a lot of maternal death actually happens postpartum from things like bleeding, sepsis from infection, and things like that. So we have to be very cognizant. So maybe I'll do more research on it, like not like an anti-vaxxer does research, but actual research, and we'll do a show on it because I think it's a really interesting topic. We'll get an obstetrician on the show. What do we got?
Pizza wants to know your thoughts on chiropractic medicine when considering its origins.
Okay, let me tell you my thoughts. The origins of chiropractic, and I'm going to be very careful with what I say here because I'll tell you why. The origins of chiropractic are abject quackery. It was a response to, this dude, and listen, I won't get into the details, but I'll say that the origins of it are very squirrely from a scientific standpoint. Now, that being said, chiropractic manipulation, particularly for back problems, for short-term acute back problems, can be tremendously helpful, it appears, based on some data. And so, and secondary, there are a lot of really science-y chiropractors, and I've done a podcast with one of them, who do a great job sticking with what they're good at, collaborating with physicians and other people in the healthcare team, and providing relief that's non-opioid. So you don't have to give opioids because these guys are doing their job right, okay? That's wonderful, and I support them wholeheartedly. But what happens is because the origins of chiropractic is this, there's this weird energy flow in the spine, and adjusting the spine fixes the energy flow. And so any health problem can be cured by adjustment of the spine. That's quack, 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 quack. It's pseudoscience. And so as a result, when they start talking about vaccines, when they start talking about adjusting babies, which they do, I get very squirrely. Now, Bobby Maybe, that's the name of the guy I did the podcast with. Just search ZDoggMD Chiropractor Podcast, and Bobby Maybe's podcast will come up. We talk about this at length. And so I support my chiropractic colleagues who are dope and who want to work together and kind of each of us stay in our own space. But I will go to war with people like Steven Bergman, who is a quackopractor. So that's a chiropractor who's a quack, who talks about vaccines, not doing flu shots, not doing vaccinations, and he's selling stuff, right? He's selling stuff. So think about, you're in Big Pharma's pocket. Whose pocket are you in, Ace? I see you on your yacht broadcasting. So you tell me, you're taking care of rich people in Laguna Beach or whatever. What we got?
Mr. 2 Mike says, comments on probiotic use after an antibiotic cycle.
So there is, I believe, some data on probiotic benefit in terms of, I don't remember if it's preventing Clostridium difficile or preventing antibiotic-associated diarrhea. So I'd have to look at that primary data again. My feeling is I don't know that it's harmful, but you may be wasting your money. So you got to be careful because we just don't know enough. Now, I'll have to review the primary literature on that and get back to you. But let me just say this. It's not so established that we're doing it routinely in most cases. But again, that doesn't mean that there's not data and that it may not be helpful. So again, I'm hedging on that one because I think there's nuance there, and also I don't have all the information in my brain.
Madeline Socks wants to know the connection with SVT and pregnancy.
So SVT is supraventricular tachycardia. And what that means is there's tachycardias, that's a fast heart rate, abnormally fast heart rate, that can start in the ventricle itself, those lower chambers, so things like ventricular tachycardia. That can be, can go into ventricular fibrillation. That's what they're shocking usually on these TV shows. Or supraventricular, meaning starting above the level of the ventricles, either in the AV node or in the atria, the two little waiting chambers of the heart, right? The pre-filling chambers. And in pregnancy, sometimes you can get these arrhythmias that are supraventricular. Now, remember that normal sinus tachycardia is a kind of supraventricular tachycardia. It's a normal speeding of the heart that comes with exercise or anxiety or certain medications, et cetera. So I don't know enough about SVT in pregnancy beyond that. We evaluate it with EKG. We can decide if we need to do any other workup. If it's abnormal, it's causing symptoms or associated with abnormally low blood pressure or very, very fast heart rates. And if the EKG is very abnormal, like something like an atrial fibrillation or something, well, then you manage that. But I'm going to defer to my cardiology and obstetrics colleagues to say how specific to pregnancy, are there different considerations in pregnancy. When I consult in the hospital, often I'm not asked to consult on pregnant women with tachycardia because usually our cardiologists manage that. So it's not something I have a depth of experience with. Hope that doesn't help.
Don Cook wants to know, could you talk a little bit on low potassium diagnosis, how it presents and why it seems so difficult to get a reason for such? Thank you.
Low potassium is an interesting problem because it can be caused by so many different things. And very low potassium can cause death, cause arrhythmia. It can cause symptoms, muscle twitching and spasm and weakness and other things like that. So it can have significant symptomatology, and it can interact with other electrolytes, things like magnesium. And so one of the things I like to think about is, again, what is the cause? If you're on certain medications like thiazide diuretics, like Lasix, your potassium can get low. Other medications can raise it, like ACE inhibitors. It can actually give you a high potassium. Angiotensin receptor blockers and things like that can raise your potassium. So you have to kind of look at the cause. There are other conditions, including renal problems. I think McArdle syndrome, I forget which ones. There's quite a few that can cause abnormally low potassium. So you really need a workup with first an internist, and if that is not revelatory, then a nephrologist, because they're really the ones that look at these electrolyte abnormalities and can make sure you don't have some type X renal tubular acidosis or something. You got to look at the other electrolytes and make sure that you've replaced things like magnesium if you're going to expect the potassium to stay up, and vice versa. These are kind of things that they teach every intern. You're the keeper of the electrolytes, so you want to make sure you know what you're doing with that. Diabetic medications can also affect potassium. Insulin can drive potassium into cells and can temporarily lower your potassium level, so you got to think about that as well. All right, what do we got?
AZ asks, are you optimistic about stellate gallium block injections for PTSD anxiety?
I don't know enough about it. I've heard about this, and the theory, I think, is that there's some hyperactivity in these ganglia, especially these sympathetic ganglia, that cause this sort of hypervigilance in PTSD. And so blocking the ganglia via injections, an anesthesia can do, or a neurointerventionalist can do, I believe, is being studied for this. I don't know enough about the success rates of it to be able to comment intelligently. It's very similar with things like ketamine. We just don't know enough yet. Now, I do know that MDMA, commonly known as Molly or ecstasy, is being studied now for PTSD treatment, and I think that has a lot of promise. There's a lot of interesting things coming in the pipeline that it's very important, because we're seeing so much of it, not even just from our returning military personnel, but from like frontline healthcare practitioners like paramedics who see these terrible things and have symptoms, for all intents and purposes, of actual PTSD.
Jake Yellow says, how long would it take to pay off medical school loans if you're on the path to become an ENT?
So ear, nose, and throat docs have a pretty decent income, but it depends on how much loans you have, how long you defer them, and what you're spending your money on. So I'll say this, it doesn't matter what your specialty is. If you have a bunch of loans, if you listen to Dave Ramsey or one of these guys that talks about debt, you can, hey, Nina, come over here.
What?
Sit with me. Because we're wrapping up now, because Victoria's got to go. Come, sit. Sorry I didn't let you be on the show earlier, but, we're talking about serious stuff. So you look this angle is not flattering for you, because we got this angle where you're just like, that's better. So anyways, what were we talking about? We're talking about loans. So when Daddy graduated, he had a bunch of student loans. What did Daddy do to pay off his student loans? He didn't buy a fancy car. He didn't buy a fancy house. He focused on paying down that debt, working, and knowing that once that debt is under control, I'll be able to sleep at night. So Dave Ramsey and other financial planners, White Coat Investor, have great advice on how to get out of debt quickly, or as quickly as you can. And it just means focusing, making that a priority, and going with that. And we'll do shows on that. We were going to call this series called Z Money, about how to manage your finances. Z Money. What do you think?
Miriam wants to know any advice on how to choose a medical charity organization to dedicate time and money to once starting practice.
So what medical charities to donate time and money to is a great question. And I'm not an expert in this, but I'll say this. I donate my time and money to Doctors Without Borders, because I have spoken for them in London at their scientific meeting. The fact that they have a scientific meeting means they're already ahead of most charities, right? So most charities are just like living in pseudoscience. Like what the hell is charity water? Like they build these wells that then, stop working. It's like, okay, listen, teach a man to fish. He has fish for his life. That's all true. What Doctors Without Borders does is, they go into these very dangerous situations, refugee situations. They provide medical care where no one else is doing it. They really try to help communities in need, especially in humanitarian disaster areas. And I found their staff and physicians and nurses and people there that work with them to be beyond heroic. So I support them personally with money and with any publicity I can give them. They asked me to actually go on the boats in the Mediterranean when there was that raging epidemic, the refugee crisis. And hey, sweetie, what you doing? You're hungry? We're gonna eat now. And I was like, sure, I'll do it. And then I pushed back out and came right back home to my comfortable first world existence, and still feel guilty about that. But don't feel guilty because I've raised a bunch of money for them through our show. So that's my answer to that. I think we gotta wrap it up. What?
I'm so tired from making note cards because I was doodling on all of that.
This was school note cards?
No.
Then what kind of note cards?
My own note cards.
So you're just making note cards?
No, I'm making note cards to study for a test. No, I'm drawing pictures to help me remember them.
For the test?
Yeah.
What test? Let's see. Risa wants to see the note cards. Pull them out real quick. Then we got to let Victoria go.
Risa Doobie?
Risa Doobie. She's Risa Dubois on Facebook. Boy note cards. Novel idea. Are they boy note cards? Because Novel Idea thinks you're making boy note cards. Like, oh, Billy is so dreamy. Do you have a boyfriend, little baby? Do you? Maybe.
Wait.
Not that there's anything wrong with that.
Wait, what was that lady?
Huh?
Was it a dude?
Show us the card.
Novel idea?
Yeah. Show us the cards.
Hey, novel idea.
Quit yapping.
This is you. Just pretend this is you.
Ow, dude.
Yeah, that's you now.
All right, now we're gonna wrap it up.
Okay, wait.
Show him
Let's see
one card. Hurry up.
See a good one.
I want to eat too.
I need to.
Dude, you're not even ready to show. These people are waiting. Victoria's got to go home.
Whelps. Okay. I made a lot.
Okay, this is dumb.
To you.
I'm tuning out. Victoria, shall we?
Okay, wait. Look.
We got one.
We got one.
This is
It's backwards.
flux. It's a Latin root. So it means to flow. And I did a guy tripping, falling into a river, toppling, dying, for temporarily dying, and then falling off a waterfall.
That's flu or flux. That's how you're learning Latin?
Yeah.
Actually, that's pretty dope. That's how I did. So people ask how do I study for like the step boards and things like that in medical school. We played The Legend of Zelda 64. Me and Dr. Harry and Dr. Diego and Doc Quixote, my colleagues from medical school, we were good friends.
Coyote?
Doc Quixote,
Doc Coyote?
Ellie Lawson, he's a surgeon, and we would sit there, play Legend of Zelda, and shout at each other different medical facts, and it's stuck in our head because like the little guy would like play the Ocarina of Time, and then I'd be like, oh, speaking of time, it's time to talk about eye cell disease, which is a metabolic storage disorder that's genetic. And we all three of us got the 99th percentile on the boards. We beat 99% of all medical students in the country. Why? Because of ish like this. All right, guys, let's say thanks to Victoria for running the show. Thank you for your amazing questions. And tune in next time we do this, which may be at any point. Stay tuned, and we out.